Hello, friends. Good evening and a warm welcome from CCI. You're very familiar with the Thursday programs, and it's a privilege for me to be a part of a CCI webinar again. The topic today is influence of influenza in the current times. I think it's a very relevant topic. It's a topic about which we were talking even before the meeting started 5 minutes ago. And the reason we are talking about this is probably the number of cases of influenza throughout the country are exceeding that of COVID at the moment. And it's not a personal experience, it's an experience all of us are sharing at the moment. Dr. Agam Vora was saying just before we started that it's not as if COVID has gone away, but it's just to prove that the number of influenza cases are even greater than the number of patients of COVID that we have just now. So I've got a very elite panel with us today. Experts in viral respiratory diseases, experts in the field of influenza, and I'll quickly introduce them and do a quick background talk for about 20 minutes on influenza. Our panel members today are Dr. Parvaiz Koul. Parvaiz Koul, I think, is the biggest expert we have in the country today on influenza. He's Professor, Department of Pulmonary Internal Medicine, SKIMS, Srinagar. And to add to that cap, he's also the director of SKIMS just now. So that's Professor Parvaiz Koul. We have Wing Commander Anuradha Ahuja with us. Dr. Anuradha Ahuja is Army Hospital RRR, Delhi. She's one of the brightest we have in the specialty just now. And it's an absolute privilege to host Dr. Anuradha Ahuja today. The next person is my dear friend, one of my closest friends in the country in the field of pulmonology, Dr. Agam Vora. So Dr. Agam Vora needs no introduction. He is the medical director, Vora Clinic, Mumbai. He's governor, West Zone CCI, and he's the general secretary of API just now. Multiple caps that I have not spoken about, but for the sake of time, I'll move forward. The next person is one of the bright stars from the eastern part of the country. It's Dr. Kripesh Ranjan Sarmah. Dr. Kripesh Ranjan Sarmah is consultant pulmonologist and sleep medicine, Apollo Hospitals, Guwahati. A very young, enthusiastic, dynamic pulmonologist from eastern part of the country. He binds the eastern part and is a representation, the face of eastern part of India in a lot of conferences throughout the country. And the last, but definitely not the least, our guest in the meeting today is Dr. Bhaskar Narayan Chaudhuri. Bhaskar is a respected senior of mine. We've worked together in the same hospital till recently, and I would never manage without his help. He's a microbiologist of repute. He's the chief microbiologist and senior consultant, Department of Microbiology and Molecular Biology, Peerless Hospital and Research Center, Kolkata. Bhaskar has many caps. He's been the face of COVID in Kolkata. You would read his comments in every newspaper in the city and see him on television on a daily basis. But today he'll talk to us about influenza, about which he's no less an expert. So that's the panel that we have today. And I'll quickly move forward and start my talk, and then we'll go to the panel. I'm very sorry. I shared the wrong talk to start with. I think we have got things right now. IT team, can you see the slide?
It's visible, sir.
Thank you. So I have named this influenza in the current decade and beyond. And what I'm going to do is to lay the platform for the panel discussion that we're going to do for going forward. I hope to finish in 20 minutes and then go ahead with the panel discussion. So influenza is not a new disease, and epidemics aren't new phenomenon either. The epidemics were first described as early as the 5th century BC by Hippocrates. And again, the description that goes with it was one of influenza. The word influenza is derived from the Italian word influenza, one of the European countries which described influenza for the first time was in Italy. The first description of an influenza epidemic was as far back as 1173, 1174. However, it took a while to describe the virus, which Bhaskar will talk about in a little while. So the first discovery of the influenza virus was as late as 1933, so less than 100 years ago. And you know, respiratory disease, which is what influenza causes, has been around for a lot of years, first described in the infective disease spectrum with TB. This is a slide which shows through the last 40 years the various epidemics in the field of infectious diseases. And I won't take you through this, but just to show that across these various epidemics and a few pandemics, influenza is dotted through. So while you have the Ebola, the Hanta, the SARS, the MERS, and this actually finishes in 2013, going forward, you would have seen COVID playing a prominent role if the slide had gone forward for the next 10 years. But you can see that while there are epidemics for individual viruses going forward, influenza is a recurring theme, and that's what makes it so very important. And that's the reason why we are having this discussion today. So influenza belongs to the orthomyxoviridae family of viruses. It's actually of 4 different subtypes. However, it's only 3 different subtypes which cause human disease, which is why we have left influenza D aside. Influenza A and influenza B are the causes of the seasonal epidemics that we see. Influenza C, while it also causes human disease, normally causes mild disease. It does not cause severe disease. Influenza A is divided into subtype based on heme agglutinin and neuraminidase protein, and I'll come back to this in a moment. And we'll also discuss this in greater detail when we have our panel discussion. However, the important factor about the genomic nature of influenza is that the heme agglutinin and the neuraminidase genes can be reassorted between different strains. As you see in the picture just above, these can be in the form of H and N, and the various genes combine, so that H1 can combine with an N1 to make it H1N1, and H2 can combine with an N2 to make it H2N2. And these combinations are there, and we'll speak about them as we go forward. A little bit about the infection and the symptoms that it causes. Now, viral respiratory infections cannot be distinguished from each other on the basis of symptoms, because the symptoms that they cause, like fever, a stuffy nose, body ache, headaches, chills, anorexia, fatigue, some non-respiratory airway symptoms like photophobia, abdominal pain, diarrhea, etc., are common to all viral illnesses, including influenza, which is our topic of discussion today. Again, across the board, in most cases, mild to moderate disease is for 7 days. The cough and malaise persists for longer, as we have seen in COVID and we see in influenza. It might persist for a few weeks. In children, the fever is far higher and the upper respiratory symptoms are lesser in case of children as compared to adults, whereas in the elderly, especially the immunocompromised, fever might be absent, and the only signs which are difficult to pick up, only symptoms which are difficult to pick up, are the anorexia, the lethargy, the lassitude, the confusion, and so on. So children and senior citizens, elderly, the symptoms are slightly varied, whereas most adults between the age of 18 to 65 will present with symptoms of upper or lower respiratory tract symptoms. The other important factor when we talk about influenza is the transmission of disease, the communicability, the transmissibility of the disease. So for adults, the symptoms appear until it's about 5 days after the disease has been transmitted that the symptoms happen. In young children, several days before illness onset until more than 10 days afterwards. And in immunocompromised, the disease might last much longer, and it can go to weeks or months. There's a lot of confusion even amongst doctors about a differentiation between common cold and flu, and often people use these terminologies interchangeably. You can see that these are not the same. And again, without reading through this slide, the symptoms of common cold are more upper respiratory and are milder. So a stuffy nose, sneezing, a bit of cough, headache, lassitude, etc. Whereas the symptoms of influenza are a higher grade of fever, headaches, myalgia, exhaustion. The post-influenza symptoms are much more prominent and last longer as compared to the symptoms that you would get with influenza. We'll talk about transmission in much greater detail when we do our panel discussion, but suffice to say, this is an aerosol-borne disease which happens within close contact. The droplets travel within a distance of 1 meter and no more than that. And airborne transmission of evaporated droplets might last for a bit longer. However, the data in any viral respiratory illness is limited, and that includes influenza. Social distancing, which has become the norm during COVID, no longer, but till recently was the norm in COVID, has also slowed down other respiratory viral illnesses, including influenza. There are two different phenomena which happen in influenza called the drift and the shift. And we'll come back to this in greater detail. But again, just to lay the background, in the cases of drift, you have a small change in the virus, the genome nature of the virus. There's mutation, but there's only slight changes in the nature of the virus. Whereas in shift, there's a dramatic change. It changes in form. If you drew an analogy between COVID and influenza, the change would be analogous to changing from Delta to Omicron. So that's a large change. And these large changes can result in epidemic and pandemics, as we see in the case of influenza, and we mentioned a little while ago. So drift is the seasonal flu, whereas shift and reassortment, large changes, result in the pandemic flu, which happens off and on, maybe once every 5 to 10 years. So seasonal flu are normally the H3N2 and in some cases the H1N1. So we get cases of H1N1 even now, but they don't always amount to a pandemic, even though H1N1 can also result in pandemics and have caused pandemics in the past. Avian flu, which we spoke about less, but is something which we see or have seen around 2010 to 2013. The H7N7, the H5N1 are avian flu. The pandemic flu is H1N1 and H2N2. The severity grade, seasonal flu is the least severe, then avian flu, and pandemic flu happens with the greatest severity. So what is greatest severity has the lowest frequency, whereas what is less severe has the highest frequency. So this is a pictorial depiction that you might want to remember. We spoke about seasonal flu, which happens every year, but there are pandemic threats that have existed since 1900. In fact, the largest pandemic that's ever happened, even bigger than the COVID pandemic that we've had, is the 1918 H1N1 Spanish flu. Interestingly, it's called the Spanish flu. It caused more than 50 million deaths, but the largest number of deaths in Spanish flu actually happened in India. So while it originated in Spain, like what happened with COVID, moved throughout the world and caused a lot of destruction in Southeast Asia, including in India. And then again, you can see through the ages, you've had a few million deaths with an H2N1, H3N1, H1N1 in 2009, which again caused close to 30,000 cases. So this is a recurring theme which happens over the years. The last one, as you see, the last pandemic was in 2009. The important factor is that the emergence of H1N1 has demonstrated the difficulty in predicting pandemics. This is the very recent paper that got reported and looked at not so long ago, which found that Asia, Southeast Asia in particular, is the epicenter for both influenza A, which is H1N1, and influenza A, which is H3N2 subtypes. However, the incidence of influenza B viruses are lesser in the Southeast Asian or even in the Asian continent. So influenza A, the two strains of H1N1 and H3N2 subtypes are common in India, Southeast Asia, and Asia. However, not the case with influenza B. This is data from India between 2010 to 2020. This is a slide I've borrowed from Dr. Parvaiz Koul. Like I said, he's done most of the seminal work in influenza. And you can see that the number of cases, lab-confirmed cases, and the number of deaths as depicted is variable. The number of deaths were high in 2010, in 2015, then again in 2017, 19, and 20. And the number of deaths are sort of consistent at about 2% or 1 to 2% of the total number. So you can see that the cases are variable, the deaths are variable, and there's a correlation between the number of cases and the number of deaths. Quickly, about some lab-confirmed Indian flu data. This is a sample population of about 13,000 with a mean age of 36 years, range of 8 months to 100 years. The time interval which is recorded here is between April 2014 and December 2017. And you can see the statewide sample mix on this particular slide. The sampling was also very variable across throughout the country, but you can see in the northern part of the country, significant numbers reported from Delhi. However, it's Maharashtra where the largest number of cases, representing 66.7% of the total number of cases that's been reported. The numbers are not reported from the part of the country myself and Bhaskar come from. So not many reports from the eastern part of the country. However, this is dependent on sampling, what gets reported, rather than an actual representation of the fact that Delhi and Maharashtra have more flu as compared to the rest of the country. So this is a depiction of the percentage distribution of total burden by age category. And you can see that the 30 to 50 year age group shows the highest contribution of H1N1 burden. So that's the blue part of the pie chart. I hope you can see my cursor. So you can see between 30 to 60 years is about 50% of the total number of cases. And younger age group, between 0 to 3 years, you still have about 10%. 5 to 18, there's another 10%, and there's representation across all age groups, but 30 to 60 years is about 46% of the total number of cases. Influenza-like illness is something that we have heard about even during COVID times. So it's an acute respiratory infection, which is characterized by 3 features: the fever, the cough, and onset within the last 10 days from disease transmission is what's the definition of ILI. The distinction between influenza disease and ILI is something which the doctor decides. Often the virus might reside in the nasopharynx of the individual. A simple correlation between clinical appearance and infecting microorganism does not exist for respiratory disease. And the labs can determine whether the microorganism causing ILI is influenza or a different respiratory viral strain. The complications of influenza, which we'll probably not come to in the panel discussion and hence important to mention, the important complication all of us see, the complication with which patients come into the intensive care unit for us are secondary bacterial infections or co-infection with a bacteria. Besides this, you've got ear infections, so otitis media, sinusitis, etc. And worsening of the background chronic medical comorbidity is something which is often seen as the congestive heart failure, asthma, diabetes as comorbidities can worsen, and the patient can have an influenza trigger which causes the worsening of these comorbidities. A quick little bit about vaccination. So the WHO recommendation for annual vaccination is for pregnant women at any stage of pregnancy, children aged between 6 months to 5 years, elderly individuals above the age of 65, individuals with chronic medical condition, and healthcare workers. So that's the WHO recommendation. The one difference that we have made in our guideline, the Indian Chest Society National College of Chest Physicians guidelines, is we have defined elderly individuals needing influenza vaccination as being above the age of 50. This is dependent on local data, and we think that in India, it makes sense to vaccinate people above the age of 50, even if they do not have a medical comorbidity of note. During the COVID-19 pandemic, who recommended vaccination with highest priority? Understandably for healthcare workers and older adults. And then the priority was similar to what I showed you a little while ago. In no particular order, it was pregnant women, people with comorbidities, and children between the age of 6 months to 5 years. This is the development of the influenza vaccine, the whole virus vaccine, which was prevalent between 45 to 64, then the second generation split virus vaccine, and then you have the subunit vaccine. The reason we have moved on is because of better tolerability. So there's good data to show that the subunit vaccine, which was discovered in 1976, has better tolerability and lower reactogenicity as compared to the other vaccine types. I'll leave the discussion for the want of time about vaccines and come back to it during the panel discussion. However, important to say that we have now moved to the quadrivalent vaccine. So that's not to say that the trivalent vaccine is no longer available, but important to understand that most guidelines, including our own Indian guidelines, say that influenza B, which accounts for a significant proportion of overall burden of influenza, is covered better by the quadrivalent vaccine. It's not possible to predict which influenza B lineage will circulate. This cross protection between the two influenza B lineages is limited or absent and substantially reduces clinical effectiveness of trivalent vaccine as compared to the quadrivalent vaccine. So I'll miss this trial about the quadrivalent vaccine and go forward. So the burden of influenza is what I'll sort of finish off talking about. The burden of influenza in healthcare workers is very, very important. So that's all of us. It's important to understand that we health workers are at an additional risk of being exposed to influenza compared to the general population. And the risk of passing on influenza to patients is huge. It's us who visit the intensive care units, see patients who are immunocompromised, and hence the chances that we transmit the disease to others if we have it is going to be greater. The risk of passing on influenza to patients who are at increased risk of severe disease, and hence they respond less well, produce less antibodies to the vaccine, even if they're vaccinated. And hence it's important that healthcare workers get vaccinated on a priority basis. We have also implied that vaccination is not just protective for the healthcare worker, it's also important for the vulnerable patients. And for the healthcare worker, it reduces work absenteeism and hence reduces disruption of healthcare facilities. And it also has important economic benefits for the healthcare facility where you work. Influenza vaccination is important for the elderly. The mortality for influenza is highest in the very young. So between the 6 months to 5 years, which is why you vaccinate them, and the elderly, which is the above 65 population. I also said that above 50 is the population that we have chosen in our country. And you can see some of the data stems from this SAGE working group background paper from 2012, which says that the age range can come down to 50. We know that the chronic comorbidities that these people might have also get triggered by influenza, and hence the burden of disease, the chances of mortality being far greater, this age needs to be vaccinated. The older you become, the greater the risk. So people above the age of 85 years were 16 times more likely to die from an influenza-related illness compared to people between 65 to 69 years. Influenza vaccination and chronic diseases, there's a long list in front of you. So any serious comorbidity, be that cardiovascular, be that respiratory, be that metabolic like diabetes, renal, liver, and so on and so forth, should get vaccinated irrespective of their age. So that's very important. This is the group which is at the highest risk of serious influenza disease. This is the group which is at serious risk of triggering the comorbidity that they already have, and hence the mortality in this group of individuals is greatest. The benefits, the economic benefits are all present in this population like we have described in the other populations we spoke about. Pregnant women is the other population group. So pregnant women are at particular risk of severe complications and death from influenza. There's a lot of reports which have come from Africa about influenza-related deaths. Similar cases have been reported, case series have been reported from Asia. The most risk is diabetes, asthma, and obesity. And the greatest risk is in the third trimester of pregnancy. There's risk to the fetus. So stillbirth, neonatal death, preterm delivery, low birth weight babies are all complications that can happen from maternal influenza. Hence, the benefit that you accrue by vaccinating pregnant women is not just protective for the lady, but also for the unborn fetus. And there's obviously cost benefits, cost saving relative to providing supportive care alone in the pregnant population. However, I have talked at length about vaccination in various age groups, but the overall coverage remains low. This shows a huge number of countries. You can see the countries at the bottom and the percentage of population which is vaccinated. And you can see that even developed countries like Norway, Portugal, Finland, Hungary, Iceland, long list of countries, the vaccination percentage for influenza is to the tune of 50%. So lots to achieve. And like it says there, vaccines would only protect if you vaccinate people. Unless they're not vaccinated, they're not going to get protected. So I'll miss a few slides. We are running out of time. We should start the panel discussion. And let me get to a little bit about pandemic preparedness. We've heard this all through COVID. It's been there for ages. World Health Organization has talked about pandemic preparedness for influenza for donkey's years. The factors that we now know by heart have been there even for influenza. So hygiene promotion, social distancing, mass gatherings to be avoided if required, needs to be with vaccination are all things that we have talked about. This is the influenza surveillance and response system. You can see India there. There's 106 member countries, lots of reference labs. You can see arrow at India, the 3 centers for global influenza surveillance and response system, the 3 centers in India and in Mumbai, Pune and Kasauli. For India, the seasonality of flu is different in different parts of the country. However, rainfall correlates with influenza peaks in most of the cities. Recent surveillance data from tropical regions of Asia have revealed a seasonal pattern characterized by year-round low level of influenza viral circulation with peaks occurring during the rainy season. The vaccine is recommended 2 weeks before the beginning of the rainy season. Most recent World Health Organization influenza virus vaccine recommendation should be used. For India, the recommendation is just before the onset of the rainy season, which is around April, May. However, like we said, it's different in different parts of the country. It's different in Srinagar and Chennai. And we'll discuss this in a little while when we get to the panel discussion. These are strategies to increase the reach of influenza vaccine. So increased vaccine access, overcoming practice-related barriers, and increased demand by consumer education and strong provider recommendation, having meetings like the ones we are having today to convince healthcare workers about the requirement of influenza is what is needed. And I'll finish off by talking about these few points which are carry-home messages from this talk. The fact that influenza is an important cause of respiratory morbidity and mortality. I think that's something which is not just in India, but globally. Influenza causes a clinical picture which is similar to any respiratory viral illness, and hence trying to diagnose influenza based on symptoms is something which should never be done. It's similar to COVID, it's similar to RSV, and so on and so forth. The investigations we'll talk about, however, having a platform, an appropriate platform to diagnose influenza with high sensitivity and specificity and rapidly within a short period of time is important, because the antiviral drugs that we use, and we'll talk about them during the panel discussion, is something that is better when administered early. The majority of times, this co-circulation of influenza B with other influenza viruses, this co-circulation of 2 lineages in most of the seasons, with vaccine mismatch in nearly 50% of the seasons. And because of co-circulation of 2 lineages, the quadrivalent vaccine, it's what is advocated in most guidelines today as compared to the trivalent vaccine. our vaccination rates are improving. However, even with the improvement, they're abysmally low. And hence, passion about vaccination, driving vaccination programs forward is something all of us should be doing together. And there's a disconnect between knowledge, belief, and practice, even within us healthcare providers, which plagues the vaccination strategies in India. And I think that's something that we all need to join hands and correct as we go forward. So that's the talk done. We've got an hour to discuss. If I could request my co-panelists, to switch their videos on. Wonderful, and Kripesh, grand. So we'll start off, guys. We'll not waste any more time. We'll start off, and I'll start off with Agam. So Agam, my friend, if you could summarize for us the various species of influenza. What are the species which you think are important in human disease? What are the natural hosts that we need to think about when we think of influenza? So we'll start off with that, and then I'll have further questions for you as we go along.
No, I always thought, Raja, you're a good friend of mine and you would ask me simple questions. Why do you have to start with such difficult questions, especially when Parvaiz bhai is there? So I think this meeting should be concluded with only Parvaiz bhai around. I mean, we will not...
Not interrupting.
I will thank you for that question. I must compliment you for the excellent talk that you gave. Of course, I'm your fan, so I like the way, the style, and the content, of course. Yes, so CCI friends, we are here again with this program, and the question that is put to me is influenza's kind of what viruses are circulating. As was discussed earlier, there are three subtypes, A, B, and C, and C is generally considered not really significant to human, and A. We all thought for years that only it is influenza A which is significant, but we realize now that influenza B also causes illness and leads to significant morbidity and mortality in few. And as Raja said, you have H and A, two different enzymes there, which gives the antigenicity, and based on these combinations, you have variety of viruses circulating. So what I understand, or what I here in Mumbai, we have a habit of asking for influenza screen. And influenza screen, we get whether it is influenza A, influenza B, because subtype is not really clinically relevant to me as a clinician. So I don't really spend much time in knowing what strains are prevailing, at least in my area. But there are times when you get these reports, and I believe there is enough H3N2 and H1N1 both. That is what is circulating at present in Mumbai. And was that all? Or there was anything?
I was asking you about the host.
Host.
Agam. Yeah.
I mean, the host of relevance in clinical practice is man to man. It's human to human transmission, which is of relevance. But yes, aquatic birds are thought to be the host. And if we know about this host, probably we may plan strategies which may help prevention. But I think that is far-fetched thought, at least at present, to my mind, when it comes to humans. And mainly what we see is human-to-human transmission.
Sure. So, quick couple of questions. I'll ask Parvaiz first, and then I'll go to Bhaskar in this context. So, Parvaiz, I mean, when you look at pandemics, when you look at epidemics of influenza, do you think the host matters more as compared to the seasonal flu that we get from time to time? So the swine flu, the avian flu, and so on and so forth. Is knowing about the host something which is important for a clinician? Or is it more for epidemiological persons, the scientists, the microbiologists, that the host becomes important?
So thanks, Raja, for that question. I mean, if we talk of seasonal flu, and as Agam said, that generally we are bothered about the human-to-human transmission. However, once we talk of pandemics or an outbreak which is out of proportion to the usual that you see, then probably the intermediate host or the host, there is a jumping from, say, avians to aquatic birds to humans. And then, as you know, the reassortment that is known to happen, generally what we call the mixing vessels, that's the pigs. And that is where the new strain forms, for which you don't have immunity at all, and that can subsequently result in a pandemic or a very severe outbreak. So
the reassortment is mainly in pigs, isn't it? So that's the where the reassortment happens.
They're the mixing vessels. Yes, they're the mixing vessels for giving a good antigenic shift.
Sure. And that's important because if you know that, you would be able to predict a pandemic going forward. Is that sort of right to say, Parvaiz?
No, I mean that this is a very unpredictable situation. You don't know when it is going to happen. What happens is that you have a reassortment. You have a component, a genetic portion of the virus that comes from the avian virus. A bit of it comes from the human virus, and then it basically reassorts in the pigs, and then a new form of virus can get formed, and that can actually lead to a pandemic, because that is something that you are not immunized against at all by way of having got infections in the subclinical form or even a clinical state.
Okay. Thanks, Parvaiz. So, Bhaskar, the quick question. I'll ask you about diagnosis and so on in a bit. But when we have seen all these influenza cases, and we were speaking about this just before the meeting started, I almost always seem to find influenza A. However, if you go through the literature, there seems to be a lot of influenza B. And even from Southeast Asia, there seems to be a lot of some influenza B. So do you think it's something that we miss, or is it that the symptoms are different? What is it because of which we don't really see much of influenza B at all?
No, thank you, Raja, for the question, and thank you for inviting me in the panel and the guest speaker here, panelist here. So, as you told, we influenza B is that uncommon because we are we are having multiplex PCR which detects influenza A and B, and in influenza A detects the subtypes H1N1, H3, N2. Okay. But influenza B, we have got influenza B cases before in the pre-COVID times mainly. Even in 2021, we got a few cases of influenza B. This time, we are not getting any cases of influenza B. It's not that uncommon in our country.
Right.
So A, B, C is very uncommon, but A and B, A is the commonest, followed by influenza B. We get it.
Yeah,
and if I may add, since we started doing this multiplex PCRs, we are picking up more of this. I don't know how important it is to look at that. I don't know how to interpret those reports, but I'm getting influenza B, I'm getting para-influenzas, I'm getting respiratory RSVs. So we are seeing a lot of those viruses which I never probably spent time in picking up those things.
Agam, you're seeing influenza B in Mumbai?
Yes, we are seeing. We are seeing on this multiplex PCR. I'm not talking about.
Of course. So we hardly see, we're getting a lot of influenza A. Believe me, we're probably getting one influenza A in every 3 or 4 patients in intensive care, and with other bugs, co-infection with the bacteria.
Oh, I see.
But hardly any influenza B at all.
So anyway, in Mumbai, there are no patients who are in ICU with...
Sorry, Agam, go ahead.
What I was saying is there are hardly any patients in ICU as of currently, of today, with influenza. Bombay is lucky that way.
So Raja, what I wanted to say is that the trouble that we were not encountering much of influenza B was because of the RIDT, that's the rapid immunodiagnostic tests that are used for detection of influenza. You usually would only detect influenza A. That is the reason that you would pick up more of influenza A. But it is, as Dr. Bhaskar said, it is known that you have a predominant circulation of influenza B in many seasons, when it certainly is much more than the influenza A.
Sure. Thanks, Parvaiz. I'll get Anuradha into the discussion. Anuradha, we've been speaking about influenza A, and I mentioned briefly about the hemagglutinin and the neuraminidase in the genomic structure of influenza A. So tell us a little bit about why neuraminidase and hemagglutinin is important, how we get these various strains of influenza A that we have talked about a little while ago. Anuradha, you're on mute.
This hemagglutinin and neuraminidase, these are the molecules, these are the glycoprotein molecules which are present on the surface of the influenza virus. And these molecules actually, they have a prominent role in virus infection and then the release of the virus. The hemagglutinin attaches to the host cell on the receptor, which has a sialic chemical, and this neuraminidase helps in the cleavage of this receptor, the sialic bond. So what happens is that once the hemagglutinin glycoprotein, it attaches to the cell, it lets the virus get into the host cell by endocytosis, and the virus replication happens. Now, this the replicated virus has to come out of that host cell so that it can infect more cells.
Sure.
So that is done by the neuraminidase, which cleaves this. So, as you've already told, how important, why is it important? Because the various permutation combinations of these 18 of the hemagglutinins and the 11 of the neuraminidase, these all combine together and they form various subtypes. Almost 130 subtypes are known. The most important, the human being being the H123 and the N12. And we have seen the various pandemics or the epidemics that have happened throughout all these years, the hundreds of the years. It is actually from various combinations only. So like the last pandemic, which was 2009, was H1N1. So the importance of these molecules is that if you can have monoclonal antibodies against these things, you may prevent the infection. But the important part here is that in spite of having the ability to target these molecules, you cannot make vaccines out of it, or you cannot handle it because there are a lot of antigenic drifts and the shifts.
Sure.
Probably this will be the next question. Probably if you want me to answer, I'll answer that. But this is the reason that, and also the various molecules which are against these particular glycoproteins are the subject of interest for the treatment of the viruses.
Sure.
So that's how these two molecules, N and H and N, are very, very important for the virus replication, release, and further prevention and treatment of the.
Sure. Grand. So thank you, Anu. I'll just, as an extension of this question, come to Bhaskar first, and then I'll go to Kripesh. So Bhaskar, Anu spoke about how the virus attaches and replicates briefly. So from a microbiologist perspective, tell us a little bit about the transmission and attachment. Also keeping in mind something which she mentioned is about how the drugs that we have, the antivirals we have, target the areas of the virus where it gets attached, of the cell where it gets attached and enters the cell, and so on and so forth.
Yes. So actually, speaking about the virology of influenza viruses, it belongs to the class of viruses known as orthomyxovirus. So orthomyxoviruses, these are RNA viruses, single-stranded, positive sense RNA viruses, and these are viruses. But like the other RNA, most single-stranded RNA viruses, the influenza viruses are unique in some aspects. So the first thing is that the viral replication occurs in the host nucleus and not in the cytoplasm, unlike the other RNA virus. So after the hemagglutinin attachment, it then enters the host cell cytoplasm and then into the nucleus and gets integrated into the host cell genome. And then it dictates the whole cell genome to produce the RNA copies. Okay. So the RNA directly, it's a positive sense RNA virus. So RNA directly helps in replication of other RNA. And then these RNA strands come out into the host cell where the other the is formed and the new variants formed. The daughter variants are formed, and then with the help of this neuroaminidase, it forms some pores into the host cell surfaces, and then comes out and infect other cells, mainly the epithelial cells of the respiratory tract. Okay, so this is in a nutshell about viral replication. And another important characteristic of this virus is that it has got a segmented genome. So it has got 8 segments which are independent of each other, this RNA. So that because of this segmented genome, the reassortment occurs very, Dr. Sir was talking about just now. The reassortment actually also in the between the A virus derived from the animals, from the birds, humans, they get reassorted, and then when a major reassortment occurs, that causes an antigenic shift, and this has got potential. And these two glycoproteins, the hemagglutinin and neuraminidase, genes which code for these glycoproteins, these genes are the mutations occurs in these genes. Just like COVID, we are seeing that mutations occur in the genes. But ACE gene, these genes are subject to mutations. So continuous mutations are occurring, and continuously newer strains are coming in. So that is known as antigenic drift. Okay.
Right.
So that is in a nutshell. And
Sure.
so the drugs and the monoclonal antibodies may not work because of this antigenic shift, which is antigenic drift, which is continuously occurring, the mutations due to the mutation. But the drugs which are targeted, they are targeted mainly. I am not very sure about the mechanism of action of these drugs. So I think some clinicians highlight more about
Sure.
that. So that is
Right.
in a nutshell regarding the history of this virus.
Wonderful. Thank you, Bhaskar. That was very lucid. You started speaking, well, Anu spoke first about antigenic shift and drift. You mentioned it again. So let me bring that question to Kripesh. So Kripesh, a clinician's understanding about antigenic shift and drift and how that influences influenza on a seasonal basis every year.
So antigenic shift and drift are the two important mechanisms that actually make the virus persist in the atmosphere, in the causing and pandemics over a period of time. So antigenic drift is actually a gradual and small changes in the gene of the influenza virus that can lead to the change in the surface protein of the virus in the neuraminidase or hemagglutinin. These small changes that occur because of the antigenic drift usually produce viruses that are usually closely related to one another. So they have usually a cross immunity. These changes are very small mutations, so they occur a prolonged period of time. But the shift is again is a abrupt and a major change in the flu virus that result in your new hemagglutinin or new neuraminidase protein in the flu virus. So this shift can result in a new flu subtype, and this shift usually happen if the flu virus from animal population gain the ability to enter a human host. Then the such animal origin virus can contain a different type of H and N in combination that are different from human virus, which then combine with the human virus or produce a new virus subtype which human will have no immunity or very low immunity. So this shift can cause a major pandemic in human population. So clinically, this shift is more important.
Sure. Okay. So shift versus drift, which brings me to my next question, Parvaiz. So Parvaiz, with COVID, we have spoken about Delta and the fact that it causes very severe disease. But we now know in hindsight that the viruses that have evolved, the viral strains that have evolved going forward, the Omicron, for instance, has greater transmissibility as compared to what Delta has, but it's become less severe disease. So with influenza and the antigenic shift and drift that Kripesh spoke about so lucidly just now, and the fact that the virus keeps changing, are there differences in disease severity versus transmissibility, depending on which strain of H and N we have? And how are these strains different as far as severity and transmissibility is concerned?
So that's a very important question, Raja. I mean, if we talk of the clinical spectrum of the disease, whether it is H1N1, it is H3N2 or influenza B, it is nearly indistinguishable on clinical grounds. You can have, as you said, that in children, you might have a different complex of symptomatology with non-respiratory symptoms, especially in elderly and very small children. Apart from that, there is very little to distinguish between the three viruses on clinical grounds, except for the fact that H3N2, for some reason, affects extremes of age more commonly than the H1N1 virus, which affects the middle age ages. And also influenza B is slightly commoner in children. That said, is is there a chance of transmissibility? Transmissibility is very varied between one strain to another, and it actually is dependent on the strain, and probably is not clinically very important, except for the fact that if you are encountering a very severe form of infection, it could be because of a strain which is A, highly transmissible, B, causing a more severe illness, and caused by a virus which probably the person has not developed any kind of an immunity to.
Okay. So I understand what you're saying, but an H1N1 and an H5N1, do you think these are different as far as transmissibility is concerned? As in,
yes, H5N1 is primarily a avian flu. It's a transmissible from birds to humans, and once it gets transmitted, then its transmission is faster and it can cause a more severe disease.
Okay.
Whereas H1N1 is usually now the seasonal flu and can occasionally cause the pandemic as well.
Sure. And a comparison between, say, H1N1 and COVID, we've heard so much about the transmissibility of the Omicron, for instance. Do you think there's any comparison between the two, or they're just different viruses with different rates of transmission and severity?
So COVID, we understood now over a period of time. Now we are 2.5 years into it, so we understand more about it. Flu, if we talk about flu transmission, it's mainly spread by droplets, and it is whenever a person coughs, sneezes, or talks, even at times, the droplets can land in the mouths and noses of people who are nearby, and they can inhale them and actually inhale them into the lungs and get infected. Less often, a person might also get infected by touching contaminated surfaces, and that was actually the transmission that was thought of in COVID as well. However, over time, we understood that there is a much lesser importance of the fomite transmission in COVID, as also that of the droplets. And now we understand it's mostly a aerosol transmission rather than droplets alone. So there's very little to actually choose between the two, but droplet transmission is more common in influenza, whereas aerosol transmission is more common in COVID.
Right. So that's an important point. I think that's an important carry-home message for our audience. The difference between aerosol and droplet, to an extent, is the comparison between COVID transmission and influenza transmission. So talking about transmission, I'll ask you something, Agam, which is, I think, right up your street and something which interests you. So in your practice in the last 10 years, what do you think is the change in active transmission of influenza? And if we can break it up, pre-COVID, during COVID, and what it is today. So pre-COVID, 10 years, and then in the last 2.5 years, how you think things have changed and how they've kept changing, especially in Indian perspective.
You're talking about
transmission.
Transmission,
Correct.
But before that, I wanted to make a comment on what you were talking about earlier. Most of us are clinicians, and trust me, we don't have to really bother much about the antigenic shift or drift which is going on. If there is going to be a major change, I'm sure Raja is going to organize a program, Parvaiz is going to come out with a paper, and CCI will host a program, and everybody will get a chance to understand that, there is a big problem coming in. Otherwise, as a clinician, treatment of influenza or the approach to influenza diagnosis and treatment remain the same. So, that's what I wanted to add.
Right.
So far as you're talking about transmission, to my mind, probably, influenza did happen earlier. Influenza did happen during COVID times, and influenza is happening now also. It's just that we are better aware about it, because cold, we never took it so seriously. Every influenzas were ignored, and most of these influenza did not lead to any complication in most of these patients, did not require any treatment, does not require any treatment even today in most of these situations. So it probably was unnoticed or not given due attention. But if you look at data, more number of people died in 2017 because of influenza across the globe than what the deaths we had in our country. So I think influenza was always there. And when I see today, I think it is possibly that we are investigating more. The reluctance of asking for RT-PCR is gone. We've got this multiplex PCR, which gives you answer in no time. I think that may be the reason. But in my limited understanding, I think influenza was there during COVID, it was there before COVID, and it is there even today.
So Agam, you feel that the greater number of cases that we see today is because of the investigating modalities becoming more sophisticated rather than actually the number of cases increasing, right?
Yes.
So I meant to ask you this. So same question again, Anuradha, and sort of to add to it, the number of reported cases in 2020 and 21 for influenza went down dramatically. If you look at influenza surveillance, the numbers were dramatically lower, and we're going up again. So what do you think explains this change? How has this peri-COVID change happened? And what do you think is going to happen going forward now that the severity of COVID has definitely come down and it's become a more endemic disease for all of us? Anuradha, you're on mute.
I feel the number of cases which were lower during the COVID times, the studies have always shown, even the pre-COVID eras, that the prevalence of influenza was always there. The surveillance studies have shown that the virus was present throughout, and they were sporadic or they were continuous transmission which was happening, and people are also suffering. But during the COVID times, because of hesitation to move out, hesitation to get tested, and also the overwhelming response and the importance given to the COVID-19. So the number of cases of influenza, I feel, were detected low. However, I feel the number, when you compare the percentage of the positivity from the numbers detected, the positivity rate was almost same. So it doesn't show that the influenza cases were not there. Probably the detection was low. This is what I feel.
Okay.
May I add a point?
Sure. I'll come to you now, Parvaiz. So I'm just to sort of, I'll come to you with a question, with a comment for this, but something to sort of add to what Anuradha has said already. So, I mean, the fact that there's a big surge of influenza cases, we've been discussing this on this platform today currently. COVID is still there. So give us a clinician's perspective also, with so many cases of influenza and COVID, as Agam was saying a little while ago. How do we actually suspect that someone can have influenza? When do we think of COVID? Do we test for both if people have these viral respiratory symptoms? What's your solution of both diseases happening with high endemicity throughout the world and throughout the country?
So first, let me talk about the COVID circulation and the effect on the influenza circulation. So during the COVID times, there was a definite slump in the circulation of influenza, and this was seen across the globe. And we have our published data. We have a regular surveillance done for influenza on all patients who come with ILI or SARI. And we did try to do COVID as well as influenza testing. And since 2020 March, we just did not have any influenza at all. And this is, I'm talking of a surveillance for influenza data. It is not that this is something that we would see out of the blue. So similar findings were reported by people who do, because there's a global surveillance network of influenza laboratories all across the world. Whoever comes with influenza-like illness does get tested for influenza, regardless of the fact whether there was COVID or there was no COVID. So there was a distinct reduction. In fact, in the southern hemisphere, there was absolutely no case of COVID influenza seen for about 2020-21. So that probably was as a result of the strict measures that Dr. Anuradha was talking about, the non-pharmacological interventions. People were not venturing out. They probably played a very significant role in the reduction in COVID in influenza circulation. Now that those non-pharmacological interventions have gone for a toss, influenza has not only come in a bigger way. It's come early. B, it's come non-seasonal. I mean, it has been reported in, for example, in Netherlands or in USA, there has been a prolonged season of influenza, despite the fact that normally it lasts, say, till April. We saw cases beyond April also. In Netherlands, we saw cases in the last quarter of 2021, which is normally not the season. So influenza is coming early, it's coming for a prolonged period, and it is coming in a severe fashion. So influenza is there. Now the question is that the two could be circulating together. The answer is yes, they could be circulating together, and we have seen now cases where influenza as well as COVID are circulating. How to differentiate between the two? Clinically, very, very difficult, except for if you have evidences of thrombotic events or maybe a loss of taste or loss of smell that might suggest that there is a COVID infection. The thrombotic event might suggest a COVID infection. Otherwise, the way forward is that you need to go for a testing because the treatment differs. We have an antiviral therapy for influenza. We have an antiviral therapy for COVID. And these are two viruses that can be treated. And I think it is important for us to tell them apart and to see whether it is COVID or it is influenza.
Sure, Parvaiz. So, Parvaiz, I've got one question for you, and then I'll go to Kripesh and ask him another question sort of related to what you said. You know, the so-called COVID-appropriate behavior, which has now become almost a legion, did not manage to stop COVID when the disease was sweeping through the country. However, it seems to have stopped influenza. So my question to you is that in a huge pandemic, the size of what we saw during COVID, do you think the transmission of other viral diseases becomes reduced anyway? I mean, it's not just about surveillance. It's also the fact that the disease process was far lesser, transmission was lesser, not just because of COVID appropriate behavior, but because of the magnitude of the COVID pandemic that we had.
There is a phenomenon that has actually been experienced previously, is that once there is a dominant circulation of one particular type of a respiratory virus, the circulation of other respiratory viruses goes down. And this has been seen in previous instances. And maybe that was also operative during the period of COVID. That's one. Second is that however, contrary to this, we had a high prevalence of RSV circulation in addition to COVID as well. So RSV did not get suppressed the same way as influenza got. And it is only hypothetical that we have put forth these possibilities that non-pharmacological interventions that we used for COVID probably did the trick. But nobody knows the exact answer why it happened.
Sure. Thanks, Parvaiz. Yeah, Anuradha. Anuradha, unmute yourself, please.
So sorry, I keep it muted. So, so what I was just wanting to discuss on this, that now that this COVID is also going little lower on the cards, and why then this influenza, which is coming up in spite of the COVID appropriate behavior, as you said, is also complying with the same seasonality of the influenza anyways. So this is the season in northern part and the lower down, as Parvaiz sir's 40 degrees north and for less than 40 degrees from the equator. 30 degrees. Yeah, sorry. So that part, I think, should cover this particular question that we are facing, that why is it increasing now more? We can always explain that it has reduced because of the COVID appropriate behavior, but this is the season. This is the season where it should increase. And this is what I feel.
Fair point, Anurad.
It's a very fair point. I mean, if you have an influenza season and you see a person coming with an influenza-like illness, that probably is the time, because of the current low level circulation of COVID, that you might be doing testing for both.
Absolutely.
Yeah. Okay. So let me come to you, Parvaiz, to you, Kripesh. Sorry. Kripesh, you know, it's easy to say that COVID and influenza are coexisting. So we should test for both if someone with moderate to severe disease comes in. I wanted to find out from you, you must be facing the same as we are doing in Kolkata and Mumbai and so on. So where is it, would you test for influenza if someone comes in with a respiratory viral infection, maybe with a superadded bacterial infection? I think Parvaiz makes a very important point that influenza is a disease that can be treated by an antiviral, which is far more effective than any antiviral that we have discovered in COVID till date. So I think that's a very, very important point. It's important to discover influenza early on, within 48 hours, and start medications. So when do you test for influenza? And B, from a clinician's perspective, I'll come to the microbiologist perspective next, but from a clinician's perspective, what tests do you have access to and how quickly do you get the results?
Yes, actually, maybe our focus on influenza has been diverted because of the COVID pandemic for last 2 years. As Dr. Parvaiz has told, we have also seen very almost zero cases in last 2 years for influenza. But recently, we have started seeing more number of serious patients with a viral pneumonia. These are because of the influenza rather than a COVID, because we do both testing for both influenza and COVID in this group of patients where we suspect viral pneumonia. And majority of patients who require ICU care or who are severe are actually influenza this time. So we actually have access to this RT-PCR for doing influenza, and we send it to the medical college, and we get it done. It is a free of cost for the patient. But what happened that once we suspect influenza, the treatment of a antiviral is much dramatic and reduces morbidity and mortality significantly than a COVID patient. So what we do that once we suspect the influenza virus, and we send sample for H1N1, and at the same time we also start empirical therapy in the moderate to severe cases and or for the high risk group also.
Grand, Kripesh. So that's very similar. I'll say something, I'll sort of emphasize on something which very important, which Kripesh says, just for the sake of reiteration. So I think if your patient is very unwell, comes in early in the course of illness, it's important to look for COVID, which you would do when you're triaging the patient anyway. But if you're sending for H1N1 and if it takes you a little while to get the report back, there's absolutely no harm in starting empiric oseltamivir, because that's something which is easy to give. It's not got many side effects, and given early, it has a much greater effect. We'll come to Agam with this question in a bit about antivirals in influenza, but I think that's an important point to emphasize on. Let me come to you, Bhaskar, that this is probably something that all of us are waiting for. We've got a multitude of tests now, and tests we don't really understand a lot about. You know, the molecular assays, the rapid influenza diagnostic techniques, the immunofluorescence, and then even there's viral cultures, which we never have access to. We understand that's something that happens in few centers and is more a research tool rather than a clinician's tool. But can you put these investigations in for a clinician? How do we position these? What do we ask for? What gives us a rapid diagnosis? What's expensive? What's less expensive?
Okay. So most of us are dependent mainly on RT-PCR for diagnosis of influenza. And it depends on the stipulations of the government also. In our state, the state government has only allowed us to perform RT-PCR. RT-PCR, real-time PCR, closed system diagnosis. The rapid tests are not allowed in our state. So I don't have much experience on rapid tests, but there are plethora of tests available. So the first is of the PCR-based test. So a nasopharyngeal swab and throat swab. Both, if you take together, just like COVID, it will yield it will have a higher yield of the. So both nasopharyngeal and transported in viral transport, we are maintaining cold chain, just like COVID. So now that is the most common specimen that although it can be done from lower respiratory samples as well, like bronchoalveolar or sputum samples also. So those are sent mainly for the RT-PCR system. So RT-PCR can be done on open platform and closed systems like GeneXpert and TrueNat. And also now we have the multiplex PCR system, which is available in BioFire. Even in GeneXpert, there are multiplex PCR which detects flu virus as well as the RSV together with that. So RSV and flu kit. So these tests are very rapid. They can detect the virus within 2 to 3 hours. Okay. And now, thanks to COVID, the RT-PCR, the done on open system, has all become sort of a rapid test. So less run time, less time for the reactions also. The reactions are within 2 hours or so. So we can, even by RT-PCR, we can, if we put up 2 lots per day, we can give a report within 4 to 6 hours. Okay. So in our laboratory, we are mainly doing it by RT-PCR as well as by BioFire. So in BioFire has got added advance that it also identifies the other viruses. There is co-infection with other respiratory viruses like or metapneumovirus, which we are getting this and other viruses like parainfluenza viruses and others. And that is the advantage. But virus isolation can be done only by cell or tissue culture, which is available in very few centers of the country, and it's very more research oriented than for diagnosis. Electron microscopy is also there in very few centers, so that is another diagnostic. And just like COVID, we have to depend on viral genome sequencing. So we have now many genome sequences in our country, which are sequencing the SARS-CoV-2 virus. But this genome sequencing for influenza is done only in NV. So genome sequencing is required to understand the mutated strains that are coming in, and for vaccine development, and the vaccine also, newer batch of vaccines are coming here, seasonal influenza vaccine. So that for that genome sequencing is mainly needed, not much for diagnostic purpose. And other two tests which are not allowed in our state are the antibody dependent and the antigen dependent. So just like COVID, we have seen the antigen for COVID, it's very specific. It detects the virus when it is present in high viral load. So rapid antigen tests are not as sensitive in case of influenza, unlike in COVID. Okay. So it's not as sensitive or specific. In COVID, they are very specific, but not very sensitive. But in influenza, the rapid tests that are available are not very sensitive or not very specific to detect the test. Another thing is the antibody-based test, but here you have to take paired sera, one in acute phase and one in the convalescent phase. Paired sera 2 weeks, if there is fourfold rise in the titer, that is diagnostic. So it's actually diagnosis done, retrospective diagnosis. Okay,
Right.
rather than prospective. So these are the tests that are available. We are mainly dependent on RT-PCR.
And so I've got a couple of questions, quick questions, Bhaskar, that short answers. One is the RT-PCR platforms, the various platforms that you described, their comparative sensitivity and specificity is very similar to each other? Or is there a variation between the various platforms that you described?
There is a variation. The most sensitive, I think, the RT-PCR, the kits that are coming in, they should be able to detect the newer viral strains. Okay.
Right.
So if you are the influenza testing is not done very frequently, if you are using a very 1-year-old kit, because these kits have an expiry of around 2 years, so you may not detect the strain. So actually, the BioFire, the upper respiratory panels, they keep on changing. So they keep on detecting the viruses. So the highest sensitivity with BioFire, so it detects the newer strains also. Okay.
Right.
And expert, but the gene expert has now done away with the H1N1 detection. So actually, as per NCDC recommendation, all the H1N1, H3N2 all now cause seasonal influenza in India. So it's actually not required to differentiate between H1N1, H3N2 and other than H1N1, H3N2, these strains, influenza B, because the symptoms will be more or less similar in all the cases and the treatment will also be similar. So, but in our state, we are required to, still we are required to differentiate between H1N1 and H3N2. Because H1N1 cases are notifiable in West Bengal.
Right.
So we have to notify H1N1. That's why we have done away with the gene expert kits, which are longer differentiating between the two. And we call that in gene expert, the sensitivity is a bit less than we get PCR or.
Sure. Okay. Yeah. Thanks, Bhaskar. That answers my second question that I had. I'll thank you very much. I'll come to Anuradha next. Anuradha, we touched on treatment already. We spoke about antiviral drugs. So your take, where would you prescribe antivirals? What would you use? For what duration? Is there an alternative to oseltamivir at all, or is it oseltamivir everywhere? Give us your take about antivirals in the management of influenza, where you would use and where you would not use. Anuradha, mute button.
So I'll give you a theoretical answer here. Sorry, this has become my, I think, the signature thing before I start my talk. So like you have influenza A, B, C viruses, you have the 3 classes of influenza disease per se. Also, like A, B, C categories have been made for these. The A categories are the usual, the ILI types. which are the cough, cold, sore throat, mild fever, myalgia, these kind of symptoms are there, wherein you don't require to test them, you don't require to give them treatment, but you require to isolate them, let them be at home, do not mix around with people. After 5 to 7 days, you can go around and do your usual routine. But then the category B, which has 1 and 2, category B1 has people who have little higher grade of fever, or little symptoms which are a little more severe than the A category. So in these cases, you may or may not test them, but you may give them the treatment as per your clinicians, however you feel that this person should be treated. But the second part, which are the people who are higher risk, we've already mentioned the high risk groups.
Sure.
You've shown us. So those higher risk groups need to be treated, tested, first of all, treated, isolated, and given a proper 7 days of isolation at home, and proper hygiene etiquettes to be followed. C categories are the ones which have been hospitalized, which are in respiratory failures, hemodynamic instabilities and all. These patients definitely to be treated and also should be managed as the ARDS protocols or other CAP protocols. Now, there are two parts of it. One, I would talk about the antivirals. So the guidelines say that within 48 hours if the patient is presenting to you, you should start the antivirals. The kind of antivirals that we have were the amantadines, which we have discontinued to use, which were the amantadine and all, because of the higher resistance. So nowadays, what we are using is the neuraminidase inhibitors, which are the oseltamivir, the zenamivir, and the paramivir. The oseltamivir is the oral drug, which is given at the dose of 75 milligram BD. There have been studies where people started to give 150 mg BD also, but the comparative studies have shown that it is the drug levels and the minimal inhibitory concentration that you need are almost the same. So in zenamivir is a parenteral or intranasal drugs. The dose is 10 mg BD. So these drugs, and also the peramivir is the drug which is a parenteral drug. People who are non-tolerant to the oral drugs can be given these intravenous drugs. It's a single dose drugs, but few of them also advised to give it for 5 days. It's a 600 mg dose. So what I would say that oseltamivir does have some side effects also. You should be very, very careful. There have been very many instances where people have jumped from the windows because it causes some sort of confusion. It's had some strong neurological after effects also. So one should be very careful about these, other than the LFTs and the RFTs derangements. The RFT derangement, they have been specifically told about the oseltamivir that if you have a creatinine clearance of around 10 to 30 ml per hour, then your dose should not be a BD dose, but should become a OD dose. So 75 mg OD should be the dose which should be given. And if you want to give a prophylaxis, which is 75 OD in the normal cases, you make it either 30 mg OD or you make it 75 alternate days. So this is a recommendation of our societies also and international societies also. And the second aspect is treating the secondary infections. So who do you treat? So do you give empirical antibiotics to all? So the answer is no, not in the OPD patients, not in the patients who have milder infection, but people who have higher risk, people who are hospitalized with hemodynamic instability, these are the people you should give empirical treatment.
So Anuradha, I'll take that question to Agam actually, but before that, I think one important message that was a very, very pertinent and very detailed message about treatment, but it's oseltamivir all the way for the high-risk group, for the sicker group of people, for the people who get hospitalized. The only indication where you think about any other drugs, especially parenteral drugs, are in patients who are unable to absorb or unable to tolerate the oseltamivir for any reason. That's the message, right? So I think that's very, very important carry home message. Agam, let me come to you on something which Anuradha finished off. This is about secondary infections. So, I was talking to you just before the meeting started, the fact that we're getting patients in intensive care, and because we are doing all these biofires, etc., we're getting plenty of patients who have consolidation on chest X-ray. consolidation on CT, you do a BAL, you get strep pneumonia, but you also get the influenza A. You get the Staph aureus, but you also get the influenza A, and maybe other respiratory viral infections. So in your book, with the more RT-PCR based tests that we are doing, what's the incidence of these co-infections, secondary infections that you're getting in Mumbai in your hospital? And how do you actually diagnose them? Do you go ahead and do a BAL? Do you try and send a sputum? Would you definitely try and obtain a specimen? Anuradha spoke about treating versus not treating the bacterial infection which is suspected. So give us your thoughts about these, please.
Now, actually, I'm feeling very bad. No, actually good. That there are no ICU patients with secondary pneumonias with influenza admitted under me. Thankfully, under anybody in the, at least at the hospital where I go. So now in OPD, we do see. So like, there are two scenarios. One is you have influenza patient, the response does well. Probably you put them on no treatment, or probably you put them on some antiviral, some zinc, whatever, khichdi masala. And after a few days, they come to you with cough, fever, and then that's classic secondary bacterial infection. You see not only in immunocompromised patients, but you see them in healthy patients as well, so-called healthy patients as well. So I am, as of now, seeing all those patients. I don't have a habit of putting them on antiviral, forget antibiotics, out of question. So I don't put them on prophylactic antibiotic or antivirals. I use it only in few patients because as was discussed, and as I'm of the clear opinion that if you don't use it in first 24 to 48 hours, it does not work. I mean, it is as good as water in my opinion, though people say that it can be used till a longer time, but I'm not happy using it a little later. And by then, that patient is not really deteriorated, so you don't need it. So then those patients don't end up receiving it. When it comes to ICUs, I mean, I did see in previous months when there was more COVID, little more serious COVID, and influenza as well. And this patient had infections, and they were admitted in ICUs, and they had variety of infections. It was not only, and in many times, it is streptococci, but you may not be able to pick up streptococci. Now with the urine antigen test, things are a little easier. You have urine antigen test giving you answer in no time, but then still the validity, still the recommendations from various guidelines are lacking. But I did see streptococci, and I did see variety of other infections as well, because we know that underlying unhealthy lung would harbor multiple bugs, and they would just wait for such opportunities to manifest into pneumonia. I mean, that's my way of talking.
No, that's great. Yes, Anuradha. So, quick comment, please. Yeah,
quick. So I just would say that empirical antibiotics, if we are wanting to give, I feel that as per me, I just keep the three main indications for it. One, if the patient has come really severe with hemodynamic instability and all. Second is if the patient has not improved after 3 days of your antivirals. And the third is when after a period of effervescence, person has again come back to have the fever. So these are the three main conditions where we must think about. We have this kind of a patient, a small thing, who has been treated for influenza outside and now he's come to us, all treated well, was doing fine, and he was sent here on some oxygen for further treatment. But now that he's bothering us with all sort of secondary infections. And surprisingly, some treatment was given at some institute with steroids, and also we've not spoken about this part. So probably we can discuss maybe 2 minutes on steroids, whether should we give or should we not.
Sure. So it's amazing the amount of variety that we have throughout the country, Anuradha. So honestly, my intensive care unit, the respiratory intensive care unit, and I'll quickly ask Kripesh about his experience in Guwahati, is actually full of people where we are growing bugs, maybe not growing bugs, but positive biofire tests, strep pneumonia, staph, gram negatives, and you also find a virus of some description. So it might not be influenza A. You can actually get a coronavirus, you might end up getting a metapneumovirus or an RSV and so on and so forth. And I'm not sure whether this is something we are picking up because the virus has caused some degree of change in the immunity, causing a secondary bacterial infection, or whether it's something that I'm picking up because I'm doing the test and is of no clinical relevance. So I think it's fascinating. And Kripesh, any comments? How is it? I know you look after a big intensive care unit where you work. Any thoughts? Is it any different?
Yes, secondary bacterial infection are very common actually. And I have seen if we even whatever the recent influenza patient that we have managed here in an ICU. So those patients who are more sick and those who require a longer ICU stay, they became tend to initially they respond well with the medication. They remain okay for 1 or 2 days, and again secondary infection comes in. They started deteriorating again. Their infective parameter goes high and death. So that is very common. So again, so the my thing is that the longer the patient stay in intensive care unit, and probably once we start a very high antibiotic at the initial part, then they make a better environment for the secondary infection, particularly for influenza patients.
Sure. Thank you. So similar experience, Kripesh. I'm happy that the eastern part of the India at least behaves in a similar manner. Let me quickly come to Parvaiz. Parvaiz, I've got all of 5 minutes, and I think Anuradha rightly has pointed out we need to add a question on steroids, which we haven't discussed till now. So I'll come with the steroid question to Anuradha after a little bit. But before that, a little bit about vaccination. So we discussed the fact that we hardly had an influenza last year and the year before. So do you think that the flu vaccine match would be different given the low levels of flu virus activity last season? Or do you think this will have no effect on the flu vaccine match that we have for 2022, sorry?
So, I mean, this is a very important question because we have had so little of circulation of influenza across the world that you have had real difficulty in predicting the influenza strain that would be contained in the influenza vaccine. But whatever little data is available, whatever from the contributory sites, they have come on to the vaccine composition, and that has actually been similar for the SH vaccine for the 2022 for the southern hemisphere and the NH for the 22-23 season for the northern hemisphere. So it generally does not have any relationship because it is a prediction. You make a prediction in February about what would be circulating somewhere in October, November, and in September you make a prediction as to what would be circulating in April based on the circulation across the globe. So I don't think that it will have a distinct influence on the vaccine and the circulating strain composition, but nonetheless, the vaccine, the influenza circulation has been so parity that there is a chance that the two may not match.
Okay. And I'll come back to Bhaskar at the end with this question, but another couple of questions I need to ask you quickly. One is, do you think from what you have said, the two different seasonalities that you talked about, do you think we should consider vaccinating twice a year for influenza in our country? Do you think that's something which the future holds?
So I think that is something that we need to think about, and I think a pilot study can be done and to see whether it is immunogenicity is better, A, B, then if it is effective in terms of preventing the influenza infection. And unless we have those kind of data available with us, it will be too premature to say that we must go for 6-monthly influenza vaccination, because that is something that could be probably thought of in a country like India. That is right. Because otherwise, as of now, the recommendation would be based on the an annual influenza vaccination based on the highest peak of seasonality in your particular geography.
Sure. So very valid. Another question for you, something which is, you're the only person probably who is entitled to answer this in this country. It's about how you need to reorient the vaccination program in this country with the pilgrimages that we have, be that the Hajj, be that the Kumbh. I know you've generated a lot of data on Hajj. There's not a lot of data on Kumbh, but I think we can extrapolate data from one to the other. So your thoughts about how the vaccination program needs to be reoriented, taking these pilgrimages into account?
So mass gatherings are an area where there has been there has been a high transmission of influenza, and influenza outbreaks have occurred from times immemorial in these settings. So Hajj, there is a lot of data available, and that's why it has become a mandatory vaccination for anybody going for Hajj, depending on the season that Hajj is actually conducted in, because it varies every year. And those data, unfortunately, we don't have much of data from the Kumbh Mela, and but it is very likely that if you have Kumbh at a time, once it is a season for influenza season, seasonality in that particular region, it's very likely that you have influenza, it will be transmitted, and it would be worthwhile having Hajj experience extrapolated to Kumbh and vaccinating these people for the strain that is likely to be circulating that time of the year.
Thanks, Parvaiz. That's food for thought. I'll quickly come to Kripesh, and I'll also ask you these 2 or 3 rapid-fire questions. So what time do you actually recommend vaccination for influenza in your patients, Kripesh?
Yes, actually, India, we have actually different types of basically flu peaks during the monsoon season, that is in July to September. So we need to vaccinate before this period. That will be your period from April to May. And again, we have a secondary peaks in winter, November to February in some part of the country. But again, they will need a different time period just before that winter period actually.
So Kripesh, for your patients, for my patients, eastern part of India, when do you vaccinate?
Eastern part, again, we have to vaccinate. Usually the peaks are mostly before the winter. So we have to vaccinate before the November month.
Yeah. So around September, October ballpark is when you vaccinate these people,
Yes.
isn't it?
Again, I have seen one interesting data that the peak period of Srinagar is matching with the southern part. Yeah, that is Tamil Nadu and
Chennai,
other things.
Chennai.
And again, the Guwahati or Kolkata and then Delhi, they have again a different peak period.
Sure. Done. So that's the reason we were discussing about vaccinating twice. There's so much of travel in the various parts of the country. So that's the, maybe not justification, but that's the reason why Parvaiz suggests a trial. Trivalent versus quadrivalent. What's your take, Kripesh? Trivalent vaccine versus quadrivalent.
Quickly, quadrivalent because it contains additional protection against influenza B. Again, trials have shown it has caused less mortality, effective in reducing mortality, and it is shown to be more cost effective in developing countries.
Okay. So if there is no choice, if cost is not an issue, it's tetravalent. That's the way we go. Trivalent probably is something that we leave behind as we go forward, isn't it? So another question, and this is important. So any gap required? What's your take between administration of the COVID vaccine, the influenza vaccine, the pneumonia vaccine, or do you think they can be given at the same time?
For COVID and influenza vaccine, we usually keep more than a 2 weeks gap between them. But again, similarly, we can give a gap for 1 or 2 weeks for influenza and pneumonia vaccine.
Sure. So that's you being cautious, Kripesh. A lot of us do that, but I think the data is that there's no gap required between any of these vaccines. There was this thought process about gap between COVID and influenza, but that's gone out of the window. So now you can vaccinate people together on the same day for all 3 diseases. It doesn't matter. So that's the current undertaking, thought process. Quick 1-minute message, Anuradha, from you for something that you brought up, which is very important, which is steroids in influenza or in respiratory viral illness.
So I'm not a proponent of it. I want to know the others' opinion. So only the indications in people with viral pneumonias or any kind of pneumonia, sepsis and all is only the hypotension, the septic shock, which is there, which allows the steroids to be given, and that also at 50 QID hydrocortisone dosage. So I'm not a proponent of it. So
So I agree with you, Anuradha. I don't think viral pneumonia or influenza per se is an indication for administration of steroids. So the ARDS that you spoke about, the sepsis that you spoke about would be indications across the board in the infective processes. But to me, I don't know whether anyone else disagrees or not, but but if not, then we'll move forward. I think there isn't a place for steroids per se in the management of any viral pneumonia, including influenza. Quickly, let me go to Bhaskar. Bhaskar, your thoughts
you
about...
have to correct yourself. COVID, something that...
COVID, yeah, sorry. Yeah, sorry, that's right, correct.
Okay, go ahead, please.
So Bhaskar, vaccines for the 2021-22, what's predicted for 2022-23, and the influence of COVID on the vaccination that's been predicted for the coming years. One message from you.
So I think seasonal influenza vaccine, as you correctly told, we are also facing troops now. For this year, I think in the monsoon, we are getting an outbreak of influenza in our although we see influenza more only in the winter in the eastern part of the country. So I think the two peaks may be caused by two different strains. So twice a year vaccination will be more helpful, because this vaccination, the antibody lasts for around 6 to 9 months, not more than that.
Sure.
So, and whenever the newer vaccine comes to circulation, this year we got the new vaccine quite late. I think in May or June. So we vaccinated our staff a little later than last year. Okay. So whenever the newer vaccine comes for the northern area, we are usually giving a vaccine. So in our country, our part, we are vaccinating in around, say, between May to August. Okay. So that during the winter, but have seen an outbreak this. And COVID vaccination also, influenza and COVID, both these vaccines now can be taken together. And I think the COVID boosters are also needed, because the COVID is also mutating, influenza is also mutating. They will keep on mutating and will keep on coexisting with each other. So we will be having peaks every 6 months for COVID, and influenza in any way having every 6 months or so. Right. So these vaccines, I think, at least for the healthcare worker, we getting these vaccines every year, at least once every year.
Okay. Sure. Grand. So thank you, Bhaskar. Yeah. So just one clarification. I think, Parvaiz, you pointed out something important. So I don't think COVID is actually an exception for steroids. I think it's an extension of the same concept that we have in influenza, etc. So even in COVID, you wouldn't want to give the steroid early. You wouldn't want to give it in mild disease. You would wait for 7 days and beyond to prescribe the steroids, especially when you start having a VQ mismatch, especially when your PF ratio starts coming down, and so on and so forth. So hypoxia would still be a trigger for giving the steroid, which is more or less analogous to any other viral pneumonia that you have. So I think an important point that you made, and we need to clarify this, that in any viral pneumonia, it's hypoxia which would be a trigger for prescribing steroids, because you think that the inflammatory deluge is so big that the steroids are needed to give the anti-inflammatory effect that is needed to try and control the disease process. And I think that's an important point which I should have made before. So thanks, Parvaiz. So I think we have come to the very end quickly. My last question will be to you. I think Agam pointed out at the very beginning, Parvaiz, that you are the master of influenza. So I'll come to you in a moment about the future of influenza vaccination. But we've got a few questions. And let me come to Agam first. So Agam, a few questions, again, rapid fire questions. There's a question which comes from Dr. Raman Mishra, who says, role of influenza vaccine in upper airway allergies, perennial or seasonal? So I think the question that he asks is, if you are prone to upper airway allergic processes, would that be an indication to administer the influenza vaccine for when there's no other indication for giving influenza vaccination?
Yes.
Okay. Okay. So that's something which is outside the guidance. So just a yes will not suffice, Agam. So one more line.
You said rapid fire question, so I said yes.
Yes.
No, yes, definitely. I would consider that as because you have many such patients who have recurrent respiratory presentations. You call it infections, you call it allergy. This recurrent respiratory symptoms, it is very difficult to differentiate at times whether that's pollution related, allergy related versus infection related. And they may have underlying hyperreactive airways. They may have underlying various things which would demand vaccination. And sure. I have been practicing vaccinating this kind of patients or this kind of population. I'm happy using it. So I would recommend that for sure.
So I agree with Agam, but this is a statutory warning. This is something which is outside the guidance, and it's something which is individual. It depends on a discussion that you have with the patient. Make sure that the patient understands.
I was talking yesterday, Raja, in some meeting. Have you seen this movie Runway 34? Which is there on the recent OTT platform?
No, I haven't yet.
This movie says that Ajay Devgan is taking a flight, and then there is guidelines in place, there are SOPs in place, there are company policies in place, there are various rules, everything is in place. But then he has to take decisions which are out of the box. Yeah. And the whole movie is about that. I was just thinking that. And in real life, you come across so many situations where guidelines don't help you. And then you have to make your own guidelines. So here we are talking about it.
Sure. No, absolutely. Agreed with you, Agam, there. Absolutely. So there's a question, Bhaskar, I'll ask you this. have you seen, so this is Dr. Amutha Rajeshwari from Tamil Nadu, Madurai, who asks, is H2N1 prevalent in this swine flu season? So I have to admit, I haven't seen it in the reports that I've gone through. Any experience? Have you seen it? I can see Parvaiz
Actually,
nodding his
this
head.
time,
Yeah.
we are getting many cases because we are doing by multiplex PCR and RT-PCR also. We are getting, it has got different targets. One target is influenza A, which is the broadest target. So whether influenza A or not, it detects. Then the subtypes, the influenza A, pandemic, influenza A, H1N1, 2009 strain, and H3N2, and influenza. So we have got several cases this year which do not belong to H1N1 or H3N2, but influenza A target detected. So these are probably the other strains in circulation. So we cannot say for sure because we are not testing for further subtyping. So we can send these strains. We have actually those strains. We'll be probably sending them to NICE or probably NIV Pune for the subtypes. Okay.
Sure. Thank you. Thank you, Bhaskar. The next question, which is from Dr. Bhavini Jayesh Gala from Mumbai. Efficacy of influenza vaccine in today's influenza scenario. I'll answer that because it will be short and succinct. So I think it's not important not to think about the efficacy of influenza and give the vaccine because it's effective, it's proven, it reduces disease and it reduces transmission of disease. So please don't think about whether a vaccine is effective in a particular season. It is effective and you should give it to everyone where it's indicated. Quick question. I'll take this across to you, Parvaiz. The risk of influenza in children below 5 years, that's a big yes, but you tell us your take.
I think that's right. I mean, you answered it. It's a very big yes. And viral infection, in fact, that is a very high risk group for complications of influenza and a group that should be targeted preferentially for vaccination.
Sure. And Anuradha, question to which I don't know the answer to. You answered the question about adults. So I'll ask you the question about pediatric population also. Treatment of influenza, which deems treatment in the pediatric population. So maybe for the last time.
One more time.
So oseltamivir is recommended and approved for children more than 2 weeks of age. So you can give oseltamivir in kids and you have weight-based dosage for them. So you can look up to it because it's some banding is there, less than 15 kg. So I don't remember exactly, but you do have it.
Sure. So oseltamivir, but we don't know the dose, guys. Please look up the dose. We are all adult pulmonologists. We don't know the dose. As a concluding remark, anyone, I'll come to Parvaiz for a concluding remark. But before that, anyone, any carry home message, a one-liner anyone wants to say before I hand over to Parvaiz and then do the thanks to everyone? Anyone?
I have a query, may not be relevant, but I think we have done almost 25, 30 programs together. I've seen you doing programs from hospitals. I've seen you doing programs from your cabin, but most of the times I found you doing programs in that room with table on next to your bedroom around the kitchen. Where are you today? It's a different background. You're in a bedroom.
It's a different bedroom. I won't tell you more, Agam, but it's a different bedroom.
Different bedroom. Makes me curious.
I'll ring you after the program, but we'll leave it there. So, Parvaiz bhai, so quickly, what does the future hold for influenza vaccination and what's new on the anvil? We hear about this universal influenza vaccine. So any thoughts, anything where we don't need to think about strains, etc.
So Agam, I'll answer this question in two contexts. One is the Indian context, and second would be the global context. For the Indian context, the new thing is that quadrivalent has actually come to stay, and probably will be the preferred vaccine for many years to come. Now, that's one. Two, and trivalent is slowly getting phased out, as it has been phased out in many other countries. Then there is a possibility that a live attenuated influenza vaccine might make a comeback, because there are some studies across the world where it has been found to be effective again, even though it was taken out of the recommendations, but now it has figured again in the recommendations too. See, then in the Indian context, we'll have to look up to other vaccines, be it the high-dose influenza vaccine, be it the cell-based vaccines, be it other other vaccine platforms that are still not yet available in the country, and they need to be introduced. And over time, as the influenza vaccine usage goes on increasing, we are certainly going to see those vaccines also being rolled out in India. On the global scale, it's very important that beyond the platforms, the two platforms that are actually of interest currently is the messenger RNA vaccine platform that was used for development of COVID vaccine by Pfizer. They're actually contemplating to use the same platform for use in influenza vaccines, and it is very likely that you might have a quick rollout of a messenger RNA-based influenza vaccine. And talking about the universal vaccine, the idea is basically, Dr. Anuradha and others talked about the hemagglutinin, and it's the HA-based vaccine that you are basically targeting. Since there is a lot of drift and shift that keeps on happening, that is why you have a vaccine which is not always matched with the with the circulating strain. So in order to circumvent this difficulty, what the scientists have tried to figure out is that they want to make a vaccine which is against the conserved portion of the antigen, and that is like the stalk of the it's a mushroom shaped antigen. If the head keeps on changing but the stalk remains the same. So the influenza the universal influenza vaccine is basically has been developed against the conserved portion of influenza antigen HA, which is universally common to all the strains of influenza, and that has been developed, that is being experimentally rolled out now, and we should be having the results soon, and it is known to be immunogenic and probably going to be effective.
Wonderful. Thank you very much, Parvaiz. We'll finish off on that note. Big thank you. I know we have exceeded time by 15 minutes. I'm very sorry for that. A big thank you to all my wonderful panelists. So Bhaskar, Anuradha, Kripesh, Agam, and Parvaiz. I learned a lot doing that meeting with all of you. I had the easy job of asking questions. So thank you very much. Big thank you to the entire audience who's tuned in and keeps tuning in large numbers, 1,000 plus in lots of occasions from CCI. I need to congratulate Dr. Ashish Dubey and Dr. Anil Maske, the new office bearers of CCI. All the very best to you guys, to Dr. Narayan and Dr. Ravi Dosi for their wonderful work that they've done over the years for CCI. And a big thank you to Dr. H.N. Krishna, who's conceived all these meetings, along with Vijay Bhai, who was there till the very beginning of this meeting. So thank you, everyone. Thank you for being there, and good night to all of you.
Thank you.
Good night.
Thank you. Good night.
Thank you. Bye-bye.
I'm expecting your call, Raja.